And this kind of makes you kind of have to understand the spinal cord, or the, the spinal cord. Okay, that didn't happen.
Is this the one where the loss of movement is the opposite side of an injury?
Correct, the contralateral, yes. It's actually not movement though, but we're going through it. But yes, that is the one. Has anyone ever had a patient like that who has looked over that? Because really you have to work in a place where there's traumatic injury, but if in a hospital that you're not going to see this really. And this stuff, you guys, honestly, you should know, you should understand, corticospinal tract. You should understand, as advanced nurse practitioners, you guys should know this stuff. That's, again, see this corticospinal tract? So, okay, Brown-Séquard syndrome. So it consists, what we're concerned about is three main tracts in the spinal cord. This is a horizontal plane. And when I say horizontal, coronal, sagittal, I expect you guys to know what I'm talking about. This is you guys looking at the spinal cord, looking down on it. If it's cut, that's horizontal plane. Okay? Okay, it's the cortical. This involves the corticospinal tract, this is pretty much all motor movement. So this basically runs our appendicular skeleton. Axial, chest, right? Appendicular arms, limbs. This is all of our movements mediated by the corticospinal. All of our voluntary movement is mediated by the corticospinal tract.
Can you see?
Can you guys see?
I don't think so.
Those three tracks, right? Well, actually, technically, it's more than that, but these are only three ones these are the three major tracks that really govern all everything in our body. You have more, which I'm not going to discuss because they're very minor and significant, with the exception of your autonomic nervous system, which is way complicated over there. That's actually the most complicated, period. Corticospinal tract, DCML, which is dorsal column medial lemniscus, that's a mouthful, and the spinothalamic. Now, corticospinal begins in the cortex, ends in the spine. Okay, that's not fair. This is dorsal column, medial lemniscus. The medial lemniscus is a body of nuclei in the thalamus. I don't expect you to know that either. And the dorsal column refers to the white matter tracts in the back of the spinal cord. So, I know it's a mouthful too. But I don't expect you guys to know that either, but I'm going to go through this in a way I think you can understand. And the spinothalamic tract, which is the spinothalamic tract is, well, let's go over each one. So, when we talk about corticospinal, we're talking about motor. Our skeletal muscles, motor. Okay? Motor, skeletal muscle. That's what the corticospinal tract runs all of that. Nine % of the axon that come down from the brain that gives movement to our body is on this tract. 9%. The DCML is the sensory tract, and that's pretty much all sensation, proprioception, fine touch, 2-point discrimination comes from the DCML. So without this tract, we wouldn't know where we were in time and space. We would be falling over on our face. So this tract is going to end up working with the eyes and the ears and the cerebellum for balance, because it mediates proprioception. Again, pretty much all fine sensation is this tract. So when you think of major motor, corticospinal sensation, you think of the DCML. And the spinothalamic is also sensory, but this is like crude, archaic sensory. I don't think I spelled that right. It doesn't matter. Okay. Crude touch, temperature. Yeah, it's considered archaic. Go figure. Those are all mediated by the spinothalamic tract. DCML, again, fine motor, fine sensory. 2-point discrimination, fine touch, proprioception. Proprioception is one of the most important things, obviously. 2-point discrimination is also. Okay, so this is your posterior horn, and this is your anterior horn. When you say horns, equal gray matter. And gray matter is just what? What's gray matter? Anyone, Harvard branch, gray matter. What's gray matter? What does gray matter consist of? What's on an axon? So the axon is what? It's whitish in color, right? So is it gray matter? Gray. It's a neuronal body. It's a neuronal body. The neural body. That's what the gray matter is. Because everything else that comes off of this is axon. It's white. Glistening white, literally. And why is this important? Why are these tracks important? Because this literally relates to all of your demyelinating syndromes. We're talking about these tracks, literally. We're talking about ALS, MS, you name it. These are the tracks we're talking about. And that's why it's kind of important. So these relate to so many different disorders. It's important for you to know. So white matter is axons. Myelination. What's myelin? Right, it's just fat. It's just like your wire, it's just the rubber on the wire. So it speeds nerve transmission. Conduction velocity is sped up by the axon. Okay? You guys all get that so far? White matter, axons. Gray matter, neuronal bodies. And so this is the anterior portion, anterior view of the spinal cord. So this is the anterior horn. And this is the posterior horn. And it's reciprocal, bilateral. I am not going to test you on that either, as I mentioned before. This is not an anatomy class. So, but anterior, posterior horn, anatomy class. Anyway. Central canal, anterior median fissure, and posterior median sulcus. A fissure is just wider than a sulcus. So this is the posterior sulcus. I'm just basically anatomical terms about location. So posterior median sulcus, anterior median fissure. Okay, corticospinal motor, DCML, dorsal column medial lemniscus, which is a mouthful, is sensory. Spinothalamic is sensory. Crude sensory, more fine-tuned sensory, and proprioception. Does everyone have that so far? Oh, that's bad. That's internet. Maybe take one section, but leave the other section open. Go figure. And no questions from Harvard branch? I can't wait till you guys are live. Let's give me something better. Okay. All right. So I have to erase this. So, actually, what's all this stuff here? This is gray. All this is gray. So all the outside is what? So what is it? All this axons. This is all axons. So think of your spinal cord. It's just a whole bunch together of these fibers going up and down. These white glistening fibers are bunched together like rope. You know, linear rope. That's what your spinal cord is basically. And jammed in the center of this of these cell bodies where these axons originate from. That's what your spinal cord is. Where does your spinal cord technically end? second lumbar vertebrae, right? Where do they do a spinal tap? Why do you think they tap below? The spinal cord. That's simply why they do it. So that's why knowing your anatomy is important. Because God forbid you stick that spinal needle, below L1, man, you're gonna have a trouble. You're gonna have some explaining to do. Sorry. Okay. So basically, didn't want to have that so far. Okay. Okay. Okay, now a little bit more explanation. So we talked about the midbrain, medulla, or pons medulla. I'm just going to explain this because a lot of people don't understand what this means, or decussate. You know what decussate means? It crosses, basically. So you have the corticospinal tract. So this is your brain. And this is, I don't know what that is. The corticospinal tract, where do you think the corticospinal tract is going to originate from? If it's for movement, the front of the brain has what? The primary motor cortex? I'm betting it's going to come from there. That's where it comes from, the primary motor cortex. Primary motor cortex. So the neurons, the outside of your brain, you ever see a picture of the brain? It's a horrible picture, but anyway, gyri and sulci, and you ever see that thick, the outer layer of the brain is that thick, darkish tissue? What are those? That's gray matter. Neurons. The inner portion is more white tissue, it's axons, because the neurons send the axons going down. So they're going to come from the primary motor cortex or the corticospinal. It's going to head caudally. It's going to hit medulla, and from both sides, right? You have fibers coming from both sides. Reciprocal, remember, reciprocal. When it hits the medulla, it's going to crisscross, or decussate, that's the term. 90% of the axons of the corticospinal tract cross over the medulla. Pretty much almost all of them, just pretty much all of them. So pretty much all the tracts for movement cross at the medulla, or decussate, right? As they cross, yes. No, let's be started. Upper branch, any questions?
Nope.
Okay. Okay, they cross the medulla, and then they go down. And these fibers are very long. These presynaptic fibers are very long because they keep going down until they reach their effector muscle. Well, that's actually not really true, but they keep going down until they reach the area of the vertebrae where they synapse to their neuron and leave. So some of these can be extremely long, like the ones going to your calf muscle, your soleus or your gastrocnemius. They start in the brain and they do not have an interneuron until they reach the spinal cord. They go all the way down, so they're very long axons, obviously. Okay. For corticospinal tract, they decussate, corticospinal, decussate at medulla. Okay, so then they enter the spinal cord. They cross medulla. Okay, now let's go to the DCML. Dorsal column medial lemniscus. Let's say this is your hand. Okay, you guys remember the Miser's core puzzle? Okay. It's a sensory receptor anyhow. Fine touch. Mine's just corpuscle. You know what? Tell me more about that. Sensory receptor. At the tip of your finger. This receptor will then shoot this signal to the spinal cord. Horrible. Okay, this is the sensory receptor. It will shoot the axon to the dorsal root ganglion, DRG. There you have a neuron. That's the first neuron. It'll interact with that neuron, and neuron will then give up another axon that goes to the spinal cord. Okay? Does everyone have that so far? So this is the DCML, fine sensory. Oh, God, that's horrible. Yeah, you know what? I'm used to lecturing in a room where I didn't have any technology and I have a board that goes across the whole room. I've done that every semester. I have that room. Sorry, you guys can see mine. Okay. Can everyone see? No one can see that, can I? I don't want to ask the question. No one can see it. Gosh, okay.
You can see most of it.
You guys can. The desk I'm on it's. One thing also around the spinal cord, and this is absolute. Okay, so that's the dorsal root ganglion here. So this sensory receptor will go all the way here and hit the neuron body and synapse to that, and this will give another axon. All sensory is in the back of the spinal cord. All the sensory fibers go back pretty much. Not all of them, but pretty much. Majority. So the posterior portion of the spinal cord is for sensory. I kind of think of it as like this. Motor is more important, so motor is in front. Sensory is less important, which I guess you could argue that point. That's how I remember it, at least. You guys can choose whatever method you want. So remember, but it originates from outside the body, outside the brain, in one of the organs, or one of the, limbs. So it comes from, like, I'm using the hands example. So the axon comes, goes to the dorsal ganglion, synapses goes to the spinal cord. And it goes to another neuron. I don't expect you to know any of that stuff about the neurons, okay? It then goes, this is the dorsal column. It's in the dorsal column. It's in the back of the spinal cord. So the DCML, all of the fibers come to the very back of the spinal cord. They go up here. So has anything crossed yet? Remember, both sides. So these go up. There's your medulla, your pons, your midbrain. You know, again. Here's your medulla. As soon as the DCML fibers hit the medulla, guess what they do? They crisscross, they decussate. So the fibers run, medical terms now, from the hand, go to the spinal cord, go ipsilateral, same side, till they hit medulla, then they go contralateral, then they get decussate to the other side. Right, exactly. It affects sensory on the, correct. So these fibers don't cross until they reach medulla. Okay? You guys get that? No questions over here? Anyone here? So the DCML, yeah, go on.
No, if you could just re-angle it, yeah.
Oh, I'm sorry. So basically, DCML, you have the fiber starting from the thing and going to the spinal cord, hitting the spinal cord and going up to the brain, same side. Then it goes to the medulla, then it crosses over. Okay? Now, for my arm, yeah, whatever. What plexus? It's going to be the cervical plexus, right? Right. It's going to be the cervical plexus it's coming from, because it's going to be the cervical vertebrae. Because remember, each vertebrae corresponds, like, the sensory motor portion of the nerve that either comes in or goes out corresponds to the level of the vertebrae. That's how we know when you have injury at a certain point where it comes in the vertebrae. It's simple. So it's hand, we're talking about hands going on the cervical vertebrae around C4, C5 level. And it's going to go, but again, it's going to go and it's going to go up the same side and across the medulla. Now the spinothalamic is different. That's the only one that's different. Now I'm going to draw one picture that shows it all together when I'm done. And I think it will make it very easy to understand then. So DCML sensory comes from the extremities, goes to the brain, crosses over the medulla. Cortical spinal tract comes from the brain, crosses the medulla, and then goes down. Okay, then the spinothalamic. It's also for sensory, but it's for more crude sensory and for temperature and things like that. And pain. Pain, temperature, crude touch. So you have, let's draw the same hand. You have all kinds of receptors in your body. It's crazy. In your hand, baroreceptors, chemoreceptors, nociceptors. Anyways, nociceptors pick up pain. So you jam your finger. It's going to be picked by a nociceptor. Okay. This is where I kind of lied. This tract goes to the anterior portion of the spinal cord, to the anterior spinal tract, and you have the lateral spinal tract. But anyway, I'm not trying to teach you that right now. But spinal tract, I want you to think of it's really one tract. You think of it as one tract, but these fibers. God, my going gets worse as they go on. That's unrecognizable. Okay. These fibers, so far it's on the same side, but I always said it's different. These are the only fibers that cross over in the spinal, in the spinal cord. They go up 2 levels. So they go up, let's say this is C4, just for argument's sake. It'll go up to C2, it'll cross over. Cross over actually here, in the anterior commissure. So this portion of white matter is called the anterior commissure. It crosses over here, then it goes up. So like I said, it's in the anterior commissure. Cross over the other side of the spinal cord, then it goes up to the brain, and does not cross over again. Anterior commissure, yes. It's like I said, yes. Thank you for Anyways, I think I won the state spelling bee. Oh, well. So, anterior commissure. We cross over the anterior commissure in this, but spinal cord. Cross over in the spinal cord. Then it goes up. So this goes. Would we say this goes contralateral or ipsilateral? The same side that enters the spinal cord is ipsilateral. If it goes the opposite side, it's contralateral. So it goes contralaterally up to the brain, and it never crosses over again. It stays on this contralateral path to hit the brain. Does everyone understand that so far? Spinothalamic, crude touch, pain, temperature, DCML, fine touch, cord discrimination, proprioception. Okay. Let's see this now. This is supposed to be spinal cord, this is supposed to be going up, but I'm. It's one word, but so it's cortical spinal mean black, okay? And remember, reciprocal. So two fibers come down, cross over. Where they cross over is called. I want you guys to know this too. I want you guys to know this. Okay, I'm just going to tell you blatantly. This is going to be on the test. There you go. They call it the pyramid because it forms inverse pyramid. See, pyramid here, right? And they call it the pyramid. So what do you think they call it? You ever heard the term? This is where you like that aha moment comes on. Pyramidal tract. That's what the pyramidal is. Extrapyramidal. What's extra? Outside of it. Any other more tracts coming outside of the cortical spinal tract is extrapyramidal. That's when we start talking about Parkinson's disease. So the pyramids. Pyramidal tract. The pyramids. That's like long. The axons are crossing. The actual physical axons themselves. Remember, you have neurons at the top of the brain giving off these tracts. Every axon has to originate from a neuron or from a receptor. Okay? Receptor and neuron, basically. Every axon has to initiate from there. So you have a neuron here. So neuron. And this would be the motor cortex. Makes sense. Neuron here. Crosses over the pyramid of medulla, or medulla, however you want to say. Okay then. And then heads down. And those actually form the lateral cortical spinal tract. But remember, guys, you have branches because this is just each of these axons is basically for a different muscle. Or you might have like complex large muscles. You might have bunches of axons for one muscle, right? If it's a very complex muscle, skeletal muscle. So would you have more axons for, let's say, your bicep, or more axons for your gluteus maximus? Right, it's a bigger muscle. You can have more axons. But I mean, common sense stuff. Okay, so basically, so these are bunches. A bunch, one bunch of axon is a fasciculus. Many bunches of axon are fasciculi. That's all it means. That's all it means. So when you hear the term anterior fasciculi or lateral fasciculi, you know where it's coming from. And fasciculi is just to think, okay, axons bunched together in a bundle. That's all it is. Singular, plural. Okay. And then they go to the respective muscles. Right? So let's say bicep. So wherever I draw on that side, it pleases the reciprocal, okay? So far easy to understand, right? Very easy. Cortical spinal, all movement of the skeletal muscle in your body crosses over medulla, and it goes straight down, and each exits the spinal cord at its respective muscle, at a level of its respective muscle. Okay. Does anyone understand? I'm losing people. Adrenaline, fast. Okay. Medulla. No, not the medulla. Let's do the spinal thalamic. It's going to be green, okay? Let's use the same bicep. So you have your, it's not a neuron, it's the pain receptor. So your pain receptor. Somebody punches in the biceps. Yeah, no, that wouldn't be very nice. It travels to the spinal cord. It crosses over the anterior commissure and goes up.
Isn't that the reflex arc that comes back around to movement?
It is a portion of the reflex arc. And reflex arcs, God, don't bring that up now. it gets way too.
Never mind. I'm sorry.
No. Does anyone know what a reflex arc is? It's not involuntary control. We literally don't. We don't control it. Right. You ever put your hand in a hot stove and like that's not, or you know what the big thing is? No, you don't have to be sorry, man. Believe me, I'm not. You never have to apologize for bringing more knowledge to people. I'll never do that. When kids fall, actually really good. Actually, I'm glad you brought this up. Now I think about it. When we fall, if we have an intact brain, that's assuming that, and kids fall, what happens automatically? Are we voluntarily putting our hands out? No, we are not. It's a reflex arc. We are not doing that. Our body's doing it for us. That's how they get the Colles fracture, right? Now you're talking about 9-year-old Joe, who's got severe encephalomalacia and had 2 strokes. He falls. His arms don't go out. He falls flat in his face. His reflex arc is gone. That's what happens to the old people. They literally will fall right in their face, which sucks. Which is painful, right? The symptoms. Okay, so the nociceptor, for pain, because it's the spinal thalamic tract, it ducticates at the, and this is actually where the fasciculi for the spinal thalamic tract. You have an anterior and a lateral portion. And for the corticospinal, you have a lateral. It's laterally. You ever see the pictures where you see like these circles, the different tracks? That's what this is basically. Okay, so the nociceptor, it ducticates in the anterior commissure. I'll write now since people actually want to know the name of it. I'm not going to test on that. I might ask you, where does the corticospinal tract ducticate at? What's the answer? Right. It's 2S or 1S? I can't remember. I think it's 1, right? Commissure? It's 1, right? Okay. Anterior commissure. Anterior white commissure. Okay. That's where it ducticates at. Okay. So now that's going up here. So is that contralateral or ipsilateral? It's contralateral. Okay. And remember, whatever I'm doing this side is going on the other side. Does everyone understand this part? Pretty simple, right? And this is a really complex condition, but it's actually, when you break it down, it's actually really not that complex once you understand the pathos. No, seriously, if someone doesn't understand, please ask me, or tell me, or say something. Huh? Yes, absolutely. Let me just write down the definition. When you say ipsi, same side. Root word, same side. Contra, opposite side. Oh, you guys can't see it again. I need more board. Okay, I'm just gonna put opposite. Okay. Yeah. Okay, so contralateral, opposite. It's just terminology. Ipsi, same side, contra, opposite side. So if you look here at the corticospinal tract, it decussates the medulla. Then once it crosses the medulla, it stays the same side forever. Period. The entire existence till it leaves the vertebral body at the foramina at its designated muscle. Corticospinal, skeletal muscle, all voluntary movement. Okay, spinothalamic. Sensory. Crude touch, pain, temperature sensation. Nociceptors. Somebody elicits that response, it's going to shoot that signal to the anterior portion of anterior or lateral portion of the spinal cord, and then it's going to cross over. This fiber is going to cross over, so it's going to go contralateral. It's going to, if it came from this side, it'd be ipsilateral. But it's crossing over, so now it's contralateral. You understand?
In the crash video, he explained it if the injury occurs before decussation, it's ISP, and if it occurs after, it's contra.
That's a good way to say it, yeah. Can you say it louder? Say it louder. Scream it.
If the injury occurs before decussation, then it's ipsilateral, and if it occurs after decussation, it's contralateral.
Right. If it occurs before decussation, right. If it, after, it's contralateral. Okay?
If it's not crossing, it's still on the same side.
Right, it's on the same side. And if you look at I like pictures personally, but you basically have the spinothalamic tract. Just know that in the spinal cord, the fibers cross over to the opposite side. It depends what right. From the top down. No, because the DCML comes from the same side, comes from the top too. They all cross at some point. Yeah. Well, they all decussate at some point. I would say they're all contralateral. The DCML is the other sensory tract, and this does not cross in the spinal cord, but it originates in the periphery, right? It originates in the effector organ. It's sensation, 2-point discrimination. So you have fibers you have sensory receptors. I'm not going to use terminology. Sensory receptors is different stuff. Well, you have specialty named sensory receptors, depending on where you're talking about your body, that pick up 2-point discrimination. That's mediated by your DCML. It's going to shoot its fibers. The back of the spinal cord, or dorsal. Dorsal is back, right? Or posterior, right? But you have you have this massive tract here called the DC, the dorsal column. And this pretty much takes all fine sensation from the legs and the arms to the brain. You have nuclei in the brain that corresponds to the name here, which I'm not going to use either, that corresponds to this column. And when we're talking about a column now, we're talking about a whole bunch of fasciculi bunched together. Okay, so it's coming from this side. It's going to the back of the spinal cord, and then it's going to travel up. And once it hits medulla, it's going to decussate. It's going to cross over. Okay, so this stays on the ipsilateral, same side when it enters the spinal cord till it goes to the medulla, then it decussates. So it's ipsilateral. Okay? No, the spinothalamic tract doesn't decussate in the spinal cord. Spinothalamic is the green. It's crossing over in the anterior white commissure, and then going up. So that one crosses over in the spinal cord. The rest of the tracts, I'm talking about the corticospinal and the DCML, they cross over in the medulla. So now you have a hemisection of the spinal cord. You have an injury to this section. So it's not the full spinal cord in that level, just over here. Say somebody comes with a knife and stabs you in the back. and it only damages half the spinal cord on one side. So you have damage here. Accident, trauma, gunshot wound, whatever. What's going to happen? Dun, 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 dun. On the damage side, what are you going to do? What's going to happen? You're damaged here. You're damaged here. So the fibers are coming down or cut. Boom, they're damaged. So you're going to have ipsilateral loss of movement, right, on the side of the damage. So where you have the injury, the side of the injury, the injury. It has, if it's a complete, then it doesn't matter. Then the whole thing is just wrecked. If it's just a hemisection, half the spinal cord, then you have this Brown cord syndrome. Okay? Harvard Branch, you get that? We good? Okay. If you have injury here, what's going to happen? So the injury is right at the motor portion. So you're going to have ipsilateral loss of motor function. Ipsilateral for the injury. So a hemisection of this portion of the spinal cord. Just half it, not the whole thing. If it involves the whole thing, then the whole and all the tracks are cut. It doesn't matter. But just the hemisection here. Just half the spinal cord is affected. Hence the Brown cord syndrome. You're going to have ipsilateral loss of muscle on that, of movement on that side. Same size. Why? Because the fibers cross over the medulla already, right? So you're going to have, they cross over here. So whatever's going on there is going on. That's going to damage the fibers which are already crossed over the medulla. So you're going to have ipsilateral loss of motor function. Let's do that. Right? Okay, now let's talk about the DCML. Right. I'm going to erase the pyramids. What does everybody think is going to happen to fine motor or fine sensory? Which is what?
It'll be IPSI.
Ipsilateral. Terminology, guys. Ipsilateral, right. Anyway, I'm not going to write them all. Okay, you get the point. Okay. Now, I did green, right? Yeah. Spinothalamic, what's happening with that?
Contralateral.
Right.
And temperature.
Exactly.
Because it's the contralateral.
Right. Contralateral loss of pain, crude touch, temp, whatever. Okay. It's, you guys, does everyone truly understand? If the hemisection injury of the cord, which is always, it's going to be a traumatic injury of some sort, gunshot wound, stabbing, car accident, whatever, piece of shrapnel goes through your, you know, and actually, at wartime, this is actually less of an uncommon injury. So if you're on the front treating you, you see this. This is something that's not that super rare. For our perspective, yes, you may see 1 or 2 patients a year if you see that many who have this injury. So contralateral loss of crude touch, temperature, pain, because the actual axon is entering on that side, right? But it's crossing over, so it's not affected. So the other side, so this side, so this poor bicep's going to be like, what's going on? Nothing happened to me, right? But he's going to lose. It's contralateral loss on this side, going to be affected. Crude touch. Because remember, what's happening, right? There's a fiber coming down from here and crossing on this side too, right? So this fiber that really supplies this is being injured. So on the opposite bicep, you're going to lose crude touch, Temperature, yes. Correct. Somebody pricks you with a needle, you're gonna go ow. Somebody touches your arm, 2 point with their fingertips, you're not gonna feel anything. Somebody burns you on this arm, you're gonna feel it. Pressure is actually considered crude touch. Deep pressure, you're gonna feel it. But any fine touch or whatever, it's all gone. Movement on this side, movement, fine touch on this side, gone. Temperature, whatever else is gone on that side. Because the fibers cross over. So contralateral loss of pain, temperature, crude touch. On the ipsilateral side, you have loss of movement and of fine touch discrimination, proprioception. So you're not going to know where this arm is, basically. Your body's not going to identify where this arm is. So you're going to have to reach out and, well, the motor report. Let's say, for instance, the motor did work. That arm would be literally useless because you wouldn't be able to direct it, basically. You'd lose, basically, orientation to where the arm is, where the limb is. Get it? Okay. Cover branch? Yep, okay. I don't know what I was supposed to cover today. I haven't even looked at my notes. No. How much to cover? How much to cover? PDA, check. How much time do we have? No. No. Dang it, I want to do oh man. Okay. I just want to go over syncope. We might run a little bit over. So, you guys want to leave? Whoever wants to leave can leave. I'm not watching. Doesn't matter. Okay, syncope. Because that's waiting. We started almost an hour late. Well, this is something you're going to see all the time. Okay, syncope. So you have a few main types. You have. Look at her. She's cleaning already. That's hilarious. Neuro. Okay, I'm just going to go over the bottom ones quickly. Neuro is anything involving circulation of the brain. This is when we talk about subclavian steel syndrome, and which I don't expect you guys to know what that is. But remember, with subclavian artery supplies the vertebral artery. Okay, I'm not going to ask you what it is, but subclavian steel syndrome and vertebrovascular ischemia. And it's and this is, you're not, honestly, I studied it to see, no, I've had one patient in my whole life and I've been practicing for a long time, that I saw with this form of syncope. It's extremely rare and subclavian steel, etc. So anything that disrupts blood supply to the brain and causes syncope is a neurogenic portion. You're not going to see that I'm just covering these ones quickly. Neurogenic, you're not going to see very often, pretty much at all. But it's caused by an ischemic effect. It's caused by a reduction, a cessation of blood supply. So what happens if blood supply to the brain is stopped? You pass out. Simple.
You also have metabolic on your notes.
Yeah, metabolic. Oh, that's actually pretty. That should be 4, really. I kind of named them in. Well, honestly, psychiatric I've had quite a few cases of that actually. Well, let's go to psychiatry next. It's actually a little bit easier to understand. Any major emotion that we have can cause a vagal response, actually, and that will literally cause you, even excitement, joy. Let's say your husband or your wife or your spouse, is in the military. They come back. You actually have people having fainting spells when they see out of joy or out of fear. any major emotional response can trigger a vagal response and cause you to pass out. So it's basically stimulating the vagal system, causing you to pass out. It's pretty simple. Excuse this one here. Metabolic, any derangement in what? Your electrolytes over in your thyroid, TSH, diabetes, sugar. So you basically have to rule these things out. So if someone comes in with syncope, and you're assuming syncope, well, actually, what's the first thing? If somebody's passing out, what's the other major thing you think of besides syncope? Seizure, right? Well, what's the one really good differentiating factor? Post-ictal state, right? Or even the presentation. If someone has an aura before they have seizures, that's a pretty good tool to use to differentiate between a simple episode versus a seizure. Also, with seizures, you have people lose bladder and bowel control. You don't have that with syncope, ever. You might have an old person that's incontinent when they have syncope, they're already incontinent, but you don't lose loss of your bladder and bowel muscles. So those are the differentiating things. You have to make sure it's not a seizure before you proceed with a workup of syncope, right? Okay. So metabolic, you're talking about electrolytes and TSH, glucose, basic stuff. So when you start things to be, this is going to be part of the work. You're going to order what? What lab are you going to order? Right. Yeah, I wouldn't order 3 people. Yeah, TSH. You can if you want, whatever. You're the provider. Well, let's do it. Okay. And psychotic, it's situational. Most people are not going to come to the doctor and say, I passed out when I saw, but that's why it's so important to listen to the patient and get the whole story before you, because would I even do any workup for this? I probably actually wouldn't. If it was a psychiatric one and I figured, you know what, this person had a huge emotional response and they passed out, I'm not going to do anything. I'm going to explain to them, but that's going to be the end of it. Obviously, if you expect the neurogenic, what would you be doing? Or you first look at the history. Does this person have a history of strokes, high blood pressure, all these things that high blood pressure, diabetes, that can potentiate that. You might want to do a cardiac ultrasound, right? Maybe an EEG, just to be sure. That's a lipid-form wave pattern. So I'm not going to ask you guys what the wave patterns are. Okay, so, but I wouldn't even, again, I wouldn't even, this is the potential workups if you suspect some of these things, because most times you're not going to need to do half that stuff. Okay, cardiogenic. How many guys would do, just out of curiosity, how many would you, right. I was going to ask a question, how many would you actually do a fasting glucose tolerance test for diabetes? A glucose tolerance test. Right. Yeah. It's not considered diagnostic yet, but those tests are torture for people who are diabetic and don't know it. I would never do it. Anyway, but just know that technically on a test, that's not the way to diagnose diabetes technically. What's the criteria for diabetes diagnosis again? Fasting glucose over what?
126.
It's actually exactly 126. How many times? Right, on 2 separate occasions. Or a hemoneurus is not diagnostic still. Right, 126, random glucose test, and also a glucose tolerance test. Technically, anyway, but whatever. Moving right along. Cardiogenic, EKG, what else? And when we think cardiogenic, we think cardiomyopathy, valvular heart disease. What else?
Echo.
Right. Anything that you could think involved, echo. If you think it's a heart attack, actually, proposal would be definitely indicated. Because you can go to cardiogenic shock, right? You're going to pass out. It presents like syncope, but it's not. Well, it is, but it's not. Okay. So these are the forms that we are much less likely to see. These are the ones that you're really going to see. Orthostatic and neurocardiogenic. Prodrome. The neocardiogenic people usually start getting sensations of nausea, dizziness, lightheadedness before the incident happens. It also can take up to 10 minutes. So you have a prodrome here. Nausea, lightheadedness. What else? My brain is wandering. Dizziness. There's more, but anyway. Diaphoresis, the sweating. So prodrome. So this has a positive for prodrome and timing. So diaphoresis, bottom one, is cardiogenic, metabolic, psychiatric, and neurogenic. What I care about clinically is the stuff you guys are really going to see. Okay? So all the stuff I ask you is going to be based on reality. So if I ask you a question about neurogenic causes of syncope, it's because I've had a syncope or I've had a seizure and I've lost my own brain function. It's not going to happen. So syncope, I want you guys to know the two big ones, by far the two biggest. And orthostatic. And these are, if you know these two, you're gold. So most physicians who practice for a long time don't remember. So basically, you have a positive prodrome and timing can be up to 10 minutes, right? So you know prodrome, and we say prodrome is really, we're talking about symptoms that we start feeling before the actual episode. Right? So if someone has sickle episodes and they said that they had chest pain, cardiogenic, right? Right. Okay. Whatever. So prodrome.